Welcome all of you, and thank you for joining us today. So I would like as well to welcome our guests, and we will have enough time to introduce each one of them during this webinar. So as you can see, our webinar for today is entitled The Role of the Pharmacist in the Fight Against Cancer, a People-Centered Approach to Cancer Care. So this webinar is marking the World Cancer Day, and it highlights the importance of people-centered care and the vital role of pharmacists can play in this approach. So we will explore how pharmacists can prioritize patients' needs and preferences in oncology care, how they can collaborate with the multidisciplinary cancer team, and how they can contribute to improving access to care, including through task sharing, definitely in low and middle income countries as well. So at the end of the webinar, attendees will gain practical insights into how pharmacists can support people with cancer, ensuring a personalized and empathetic approach to care that places the patient at the center of the treatment process. This event aims to empower pharmacists to make a meaningful impact in cancer care. So it's my pleasure to be your moderator for today. As you can see, my name is Aline Hajj. I'm the global lead for the Development Goal 10, Equity Equality at the FIP. I'm also a professor at the Faculté of Pharmacy, Laval Université in Canada, and I'm a researcher with a dedicated focus on oncology, psycho-oncology, and palliative care. My research work focuses on how we can have a holistic and personalized approaches to pain management, particularly for individuals with complex conditions such as cancer. So I always promoted the role and the important role of pharmacists that can have in bridging science to practice to ensure that the patient would have a safe, effective, but above all, a centered approach. So as you can see on the slide, we have some announcement to make before starting with the webinar. So please know that this event will be recorded, live streamed on FIP YouTube, and the recording will be available at event.fip.org. To all those who are listening, please feel free to send all your questions through the Q&A box provided. I'll do my best to manage to send all the questions to the speakers at the end, and we will be able to address all these questions. You are also welcome to provide any feedback to webinars@fip.org. And I would like to take this opportunity to promote and benefit the membership of FIP, including webinars and events. FIP, as you know, is a global body that represents over 4 million pharmacists and pharmaceutical scientists. And if you're a pharmacist or pharmaceutical scientist and you would like to become a member, please go on the FIP website and register, the fip.org. So there's one new thing for this webinar. So you can use new translation feature on Zoom. If you'd like to turn it on, so you just have to turn on your captions, then you have to enable the translation toggle, and then you have to choose your preferred language under my caption language, so as you can see on the slide, and then you can follow with the live stream translation captions. We would like to acknowledge as well that this event has been developed in collaboration with the International Society of Oncology Pharmacy Practitioners, ISOP. So we will be speaking about it in a moment. So for this event, I'm really happy to be joined by a panel of fabulous speakers, and I would like to sincerely thank each of them for taking the time to prepare the presentations, and we will go all through their presentation in a moment. So for today's program, as you can see, we will start with a brief introduction about that I will do myself, so about a little bit the program that FIP has developed regarding NCDs, but in particularly about cancer. Then we will have 3 different presentations. The first one is by Nettie Cracknell, so regarding the role of the pharmacist in a people-centered approach to cancer care. Then we will go with Nick Duncan for the UK perspective about the delivery of pharmaceutical care in patients with hematological cancers. And we will finalize it with how we can have some sharing task sharing about how to improve cancer care across low and middle income countries from UTOTO, from the University of Toronto in Canada. Okay? So today's learning objectives, we understand that at the end of this webinar, each of the attendees will be able to understand the principle of people-centered care and its relevance to pharmacy practice. Then you will be able to explore the role of the pharmacist in promoting people-centered approaches within a multidisciplinary team, of course, oncology team, that includes task sharing to improve access to care. You will be able to identify strategies to support cancer patients, including management and treatment of side effects. And finally, you will be able to gain some practical knowledge to improve the quality of life of patients that are living or affected by cancer. So to start with a brief introduction about the webinar and the role of FIP that has played in cancer care. So it's important to state that in 2018, the WHO organized what we call the Global Conference on Primary Healthcare, and it was held in Astana in Kazakhstan. So that was a very important moment for the FIP because for many years, the Federation has been working on advancing our profession driven by a single and a very important vision of a universal healthcare access and coverage for all. So in that context, the FIP signed the Astana Declaration on behalf of the profession to ensure that the pharmacy contributes to the delivery of this universal healthcare coverage by 2030 through its role in primary care and healthcare. So they established as part of the commitment, the FIP developed and established what we call the non-communicable diseases program that aims to deliver the commitments to this WHO Astana Declaration on primary healthcare. So if we have to go and look deeper into this program of, next please, if we have to look deeper into this this slide or this concept of FIP practice transformation program. So one of the ways is that FIP that established this program. So what was this program? This program helps or provides a tool and strategic support to FIP member organizations to help them develop and implement pharmacy services that can sustain positive impact on prevention, screening, management, and treatment for the NCDs, non-communicable diseases, to improve patient outcome and healthcare system efficiency and sustainability. Next, please. So this program initially focused on 5 disease areas. So they stated that we have 5 main disease areas where we can act as pharmacists. And they stated that we have diabetes, we have mental care and mental health, we have chronic respiratory diseases, we have cardiovascular diseases, and of course, why we are interested by it now, it is we have also something related to cancer. Next, please. So they did not only develop these 5 diseases and stated that we have to do many things regarding these diseases, but also they stated that we have to focus as well, not only on the diseases, but also on the risk factors and what we can do to prevent these risk factors, or eventually to better give maybe advices by pharmacists regarding these risk factors. For example, it could include something related to tobacco use, to stress, to alcohol consumption, and eventually nutrition and weight management. So whether related to these disease areas or the different 5 diseases, so they stated, the FIP stated that we can have 5 areas of pharmaceutical intervention. So the pharmacist would have 5 roles, or eventually 5 interventions where we can have a main role. So it could be about the disease prevention. It could be about disease screening and risk assessment. So namely the point of care test and so on. It could be how we can have a referral to other healthcare professionals, because we should never forget that we're working with a multidisciplinary team. So we have to have this interprofessional collaboration. Then the 4th point would be the disease state management that includes patient follow-up, support to prevent disease, and disease progression. This is what we'll be doing and seeing with our speakers. And finally, it could be related to what we call the treatment optimization. That means it could be related to adherence to treatment. It could be related to medicine use, to medicine reviews, and medicine reconciliation. Okay. So all of these, as you can see, this program is very important, and it is at the core, it is aligned with what we call the FIP development goals. So for those who are not really knowledgeable about the FIP development goals, so the development goals that were developed by the FIP stated that we have different objectives that we can have. So in this content of cancer and cancer people's approach, you definitely can see that we might have 3 important and primary goals, which are the definitely number 15, which is people-centered care. This is the main objective of our presentation and webinar for today. It could be also because we are medicine experts. So 14 is medicine experts, and we have the medicine expertise. And we are working on advancing integrated services within multidisciplinary teams. Then they stated that we can have other secondary and tertiary goals, including, for example, how we can improve safety of the patient, how we can also, for example, have how we can use artificial intelligence to improve our work, how we can have some competencies, how we can make impact and outcomes, and so on. So if I have to discuss a little bit more about the most important point for this one and the most important goal, which is development goal 15 for the people-centered care. So, for the FIP, for each of the goals, we have 3 different categories. We have the practice, we have the workforce, and then we have the science. So at the practice level, the FIP would like to promote the collaborative interprofessional strategies, how we can have a people-centered professional service to support, as we said previously, the prevention, the screening, the clinical management, and the therapeutic organization of the non-communicable diseases. And in this webinar, we will talk mainly about cancer. Then regarding workforce, it would allow us how to promote, and the FIP would like to promote strategies to develop pharmaceutical education and the workforce to be able to support the delivery of people-centered care in practice. And finally, regarding science, we would have as researchers the capacity, how we can promote the capacity to monitor, to understand health-related characteristics that would lead to innovative, personalized approaches for improvement of people-centered care. And this is what we will be discussing during this webinar. Finally, I would like to mention that the FIP has made a lot of effort to support all FIP and FIP member organizations with this people-centered approach regarding their maybe management of patients with cancer. So as you can see on the slide, we have 2 excellent notebooks and handbooks that you can check either when checking on your the link above, or eventually you can scan your QR code. So the first one you have is what we call the Cancer, a Handbook for Pharmacists. So this handbook identifies and describes the pharmacist-led intervention in cancer prevention, screening, management, and treatment optimization, and how they can maybe support the implementation of a pharmacy practice towards the optimization and the expansion of the pharmacist practice in cancer and NCDs in general. So this is a very, very, very important, and it's really easy to implement. So I really invite you to check it and to see the details. And the second one you have on your right, so it is what we call the FIP Knowledge and Skill Reference Guide for the Professional Development in Cancer Care, that was also published in 2022 and is somehow maybe complementary to the first one. So it is to improve how we can improve our knowledge and skills that are related to support the pharmacists with their, how they can develop, how they can upskill, how they can refresh the knowledge about cancer care and the related roles. And then they will help them to implement both maybe these strategies within that with improving their skills. Okay, so I invite you to check them on this presentation, after this presentation. So with that being said, and expanded on the role of the FIP in management of patients with care, with the patient maybe centered care. So it would be my pleasure to present our first speaker for today. So thank you for joining us, Nettie Cracknell. So Nettie Cracknell has over 20 years of experience as a specialist cancer pharmacist in the UK. And she has been working with the UK government and private organizations. She's passionate about improving cancer care globally and how we can improve as well the safety for the patient and the staff, but by utilizing the digital education and training for pharmacy staff in all sectors and countries. So Nettie is also the president of the International Society of Oncology Pharmacy Practitioners, and she's a fellow of the both Royal Pharmaceutical Society and the British Oncology Pharmacy Association. So Nettie, thank you for joining us. You will be discussing about people-centered approach for cancer care, the role of the pharmacist. So the floor is yours, and I'll leave you to your presentation. Thank you so much.
Thank you so much and welcome everybody. So I qualified as a pharmacist in the UK in 2002 and I got my first job as a cancer pharmacist in 2004. And this was at a government general medical hospital. It was a brand new post to the organisation. They didn't have cancer pharmacists speciality before then. And they'd started to see that they needed pharmacists with specific cancer training. Since then, I've worked in various government and private roles in cancer. And I started to volunteer for the British Oncology Pharmacy Association, so BOPA, from 2005. And I started to volunteer in ISOP in 2019. And I'll tell you a little bit more about ISOP later on. So the objectives of my talk today is to cover the key principles of patient-centred care and how they differ from traditional models of care in oncology, exploring how pharmacists can tailor care to patients' individual needs, preferences and cultural context, and strategies for pharmacists to ensure informed decision-making and improve patient satisfaction. But before we go on to that, I'd like to just cover very quickly a little bit of cancer statistics. So in 2022, it was estimated that there was 20 million new cancer cases. And in 2050, it has been predicted that there will be over 35 million new cancer cases across the world. This has an increase of 75% in 28 years. So this rapidly growing global cancer burden is a concern for all countries as they struggle with caring for their growing number of patients with the limited resources and workforces that we have. So if we look as to why the cancer rate is increasing, we have an increasing aging population, we have a growing population, we have exposure to tobacco and alcohol, increasing obesity and air pollution. And some of these risks can be lowered by modification of lifestyle. So going back to the original talk, which is around people-centred care. So people-centred care is around healthcare that is respectful of and responsive to the needs, preferences and values of individuals and their families. And we focus on patient autonomy, quality of life and multidimensional care. And the important thing is that we are treating the person, not just the disease. So when you're treating the person, not just the disease, it's about collaboration. So every person is unique. We empower them to actively participate in the decision-making process. We want to hear their concerns with compassion and empathy and help to create autonomy rather than simply being passive recipients of care. It's about connections, the importance of social ties and engaging individuals, families and communities to better meet that person's unique physical, mental and spiritual needs. And it's about community. The benefit of being informed and engaged and improving the health literacy and self-care. People are more than just patients, and before they ever interact with the healthcare system, they benefit by being informed and engaged and around that community. So we do talk around patient care, person care, people care. So what are the differences? So patient-centred care respects a patient's feelings, values and preferences about their own care. It emphasises the importance of treating patients as partners and can involve shared decision-making. Patient-centred care specifically relates to the clinical context and interactions with the healthcare system. Person-centred care expands the focus beyond the patient to the individual as a whole person and considers all aspects of their life, not just their disease. It values people's unique experiences and wishes, including psychological, social, and spiritual needs. It supports the individual in a holistic manner, taking their personal life, identity, and social context into account. And then people-centred care takes the most valuable elements of the patient and person-centred models and places them within the broader context of community. This model has the widest possible view as individuals actively participate in their treatment and their experiences, and their values are heard and respected, whilst it engages their family, their social connections, the wider community, and pillars of high-quality cancer care. All of these approaches are essential for delivering comprehensive and effective healthcare. And while World Cancer Day campaign theme this year particularly highlights people-centred care, it does of course encompass the key elements and driving force of both person and patient-centred care approaches. So I'm going to now take this looking at people-centred care and pharmacy. So how does pharmacy fit in? So within cancer, it's a complex area. And globally, we have different education about cancer at undergraduate level. We have different availability of formal postgraduate training programmes. There may or may not be assessment of competence. There may be a standard of training across different nations. There may or may not be a national recognition of cancer as a therapeutic area of treatment within countries. And as a disease area, it is fast moving and new treatments are always coming on board, and increasingly they are quite expensive. So if we just go back to looking why cancer burden is increasing, and we look specifically at the exposure to tobacco and alcohol and increasing obesity. So these are the risks that can be modified by lifestyle choices. All pharmacists can deliver people-centred care to all patients. We are the first point of healthcare contact in most countries. We have connections in the community. We know our local demographic. We have knowledge of the cultural context where we work, and we already have the healthcare relationship with individuals. This is where pharmacy can have an impact. They are key for early detection advice, and they are key for prevention strategies. But they are also useful, and pharmacists can also be involved in delivering people-centred care to cancer patients. Pharmacists can help with side effect management for chemotherapy or SAT, which is systemic anti-cancer therapy. They can help with the procurement of treatment. They can act as an outpost or a spoke for SAT administration, depending on geographical challenges. And they can support and signpost for mental health support for patients and carers. Now, if we look specifically at pharmacists who have specialised in cancer services, traditionally, we can ensure appropriate drug selection and dosing with regards to chemotherapy. We can look at protocol writing and checking, how to prevent medication errors and adverse events, participation in tumour boards and treatment planning, and we have a role in clinical trials and research. And with specific training, pharmacists can specialise in these cancer services. But how do we take the next step to ensure the person is at the heart of the decisions we make and not the disease? I'm now going to go through 3 examples. So looking at monitoring drug interactions and toxicities and how we can work with the patient to manage these. The example I give you is a patient who has been prescribed routine dexamethasone to prevent nausea and sickness. Very common, in cancer care. And in discussion with that patient, you find out that actually they would prefer to feel sick rather than have some of the side effects of the dexamethasone, such as gain weight or have nightmares. And as cancer professionals and pharmacy professionals, we can talk to that patient and we can say, okay, let's have a look at your dexamethasone, let's see if we can reduce it, let's see if we can stop it. But we're medicine experts, so let's see if there's something else we can do to help prevent your sickness. You need to treat the unique patient. The next example is around ensuring drug selection and dosing with regards to protocol writing and checking. So when pharmacists are writing protocols to make sure that information is contained so that the people on the floor have the information that they know to have their spiritual beliefs considered. So an example here is gelatin. If gelatin is contained in medicines, this should be stated in the protocols and the medicines information so that healthcare staff have the knowledge to discuss with patients who have a preference to avoid gelatin. Examples of cancer treatments that contain gelatin are things like temozolomide or sunitinib. And as medicines experts, we can help support our patients. Again, treat the unique patient. My next example is around preventing medication errors and adverse events. And these are adverse events that are not listed in your data sheet and they're not listed in the literature because it is a patient effect. An example I give here is a patient with irritable bowel syndrome, the IBS. They can't tolerate lactose. And so they will stop taking any medicines that contain lactose because they get stomach cramps, for example. And if they have stomach cramps, they can't work. And if they can't work, they can't earn. And so they actually just stop taking this medicine. And what we can do as medicine experts is we can talk to that patient. We can find an alternative. It may even just be a different manufacturer. Again, treat the unique patient. So we do have challenges. We have resource limitations. There's lack of specialised training. There's a lack of potential local peer resort. But there are opportunities as well. We can help. And we have the knowledge to improve someone's experience at this difficult time. And there is a role for expanded pharmacist roles. And there's also the need for continued education and professional development. As I said earlier, cancer is a fast-moving disease area that changes quickly and significantly. And looking at education, I'd like to just bring your attention to our UTIC course. So this is Understanding Targeted Therapies and Immunotherapies for Cancer. This course was developed by ISOP and BOPA, and it has been given the FIP seal of approval, and this is awarded to professional development programs and courses that provides a visible signal to the alignment of a provider for programs with the FIP mission to advance pharmacy worldwide. This course is free to access as an ISOP member, and it contains 5 modules which have 24 videos, but these videos are bite-sized, so they're 6 to 8 minutes long, so you can just watch them on your commute to work, for example. And with ISOP, our mission is to advance oncology pharmacy care globally. We want to empower pharmacists to make a meaningful impact in cancer care. And ISOP connects pharmacists globally for research, mentorship, collaboration, and has education provision to support you to learn in the cancer field, an example being the UTIC course. We also have our standards of practice. And the most important thing is ISOP has no fee to join. There is no monetary requirements to join ISOP. You just need to be invested in oncology pharmacy as an area. So in conclusion, pharmacists are key to people-centred healthcare. And within cancer services, the treatment options are often complex, and pharmacy has a pivotal role to help support patients and their carers. And pharmacy can have a positive impact in communities by education through early detection and prevention strategies. I'm going to leave that here, and now we will see some examples of how pharmacists can intervene to improve adherence, manage side effects, and ensure quality of life. Thank you very much.
Thank you so much, Natty, for this excellent presentation and the really interesting examples you gave. So at the end of the presentation, we definitely have several questions related to how we can access ISOP and so on to gain knowledge, and we will discuss it in a moment. Thank you so much again. So now it's my pleasure to welcome our second speaker for today, as well from the UK. So thank you so much for joining us, Nick. So Nick is a consultant in hematology, and he's a hematology pharmacist at the University Hospitals Birmingham NHS Trust, and he's an assistant professor at the School of Pharmacy, University of Birmingham. He's a fellow of the British Oncology Pharmacy Association and the Royal Pharmaceutical Society of Great Britain, and he's currently the chair of the ISOP Research Committee. So it's our pleasure to introduce you and to listen to your presentation today. So what you will present today is related to how we can deliver pharmaceutical care, and we definitely are talking about people-centered care to patients, but in particular with patients with hematological cancer, and we can see how the UK perspective from your side. So the floor is yours. Thank you so much.
Thank you very much, Aline, for the nice introduction, and thank you to FIP and ISOP for the invitation to present today. So to kick things off, if I can just move my slides. There we go. So just a little bit of background about myself. I qualified as a pharmacist back in 1994, and I was very lucky. My first job after qualifying was as a junior pharmacist at the Royal Marsden Cancer Hospital, which is a specialist cancer hospital based in London and has a worldwide reputation as a centre of excellence. And I think that's where, understandably, I got my love for working in cancer services, and that kind of set the foundations for my future career. I then spent a year and a half working in Namibia in a hospital in a town called Oshakati for an organisation called Voluntary Service Overseas. I returned to the UK in 1998, and for the last 25 years, I've been working at the Queen Elizabeth Hospital in Birmingham, working initially in oncology, subsequently in hematology, and then in 2016, I became a consultant hematology pharmacist. This is a relatively new concept within UK pharmacy circles. Just to explain what, as a consultant hematology pharmacist does. So I work as a non-medical prescriber in a variety of hematology clinics. So I'm seeing patients who perhaps historically would have seen a doctor, a medical doctor, but now would possibly see a pharmacist or a nurse as part of that more multidisciplinary approach to cancer care. I deliver specialist clinical pharmacy input to hematology inpatients and outpatients, and I also have a role in undertaking and supervising patient-focused research in this area. And very importantly, I'm expected to provide educational inputs at a variety of levels. So we have a School of Pharmacy at the University of Birmingham, which is next door to our hospital. So I have the privilege of teaching pharmacy students about cancer and its treatment. I also organise placements and projects for the pharmacy students. And within my more day-to-day role within the hospital, I'm there to provide both formal and informal teaching to pharmacy colleagues and the wider multidisciplinary team. And very importantly, I'm there to educate and support patients through their treatment journey. And in my presentation today, I want to focus on that aspect and, hopefully give some examples of practice that are. To start with, I want to talk a little bit about adherence. We know that adherence to medication is a challenge in whatever area of healthcare we are working in. And I've always been very much struck by this quote from a WHO adherence report from back in 2003, which stated that increasing the effectiveness of adherence interventions may have a far greater impact on the health of the population than any improvement in specific medical treatments. And I think this is a quote that we are perhaps guilty of sometimes forgetting about. I think there is always this understandable desire to develop newer, novel, usually more expensive treatments for our patients. And again, this doesn't just apply to cancer, but I think it's particularly relevant in terms of cancer treatment. But actually, if no matter how good the drugs we have are, if patients aren't taking them for whatever reason, then that is clinically significantly detrimental to those patients. And actually, we need to be focusing on supporting adherence in our patients. And I do remember when I first started out as a cancer pharmacist and I read about problems with adherence, you know, half of people with high blood pressure don't take their blood pressure medication. I used to think, well, that's all very well for someone with high blood pressure. Perhaps they are asymptomatic. They don't realize the importance of taking medication. Surely it will be different in cancer patients and adherence will be 100%. And clearly, you know, that is not the case. And there's many, many examples of this. And this is a paper, again, an old paper, but still an important paper. This was a study looking at patients with breast cancer who were prescribed adjuvant tamoxifen after they'd received their surgery. And they were recommended to take a daily tamoxifen tablet for 5 years. So not a particularly onerous schedule, once a day. However, after a year, over a fifth of patients had stopped treatment. And after 3.5 years, over a third of patients had stopped treatment. So I think it's important to emphasize that a cancer diagnosis does not automatically mean that patients will be adherent to their medication. But you may then ask the question, well, does this actually matter? What is the clinical significance of suboptimal adherence? And again, there's some very compelling data out there. My area of specialization is chronic myeloid leukemia, and we'll talk about this in a little more detail in a moment. But I've always been struck by this paper. Again, it's quite an old paper now. It was from a group from the Hammersmith Hospital in London, led by David Marin. And this was a study looking at adherence in patients taking imatinib. So this is an oral tyrosine kinase inhibitor that is taken daily and is highly effective at controlling the disease and giving patients basically a normal life expectancy. And in this study, they found that between 1 in 4 and 1 in 5 patients had suboptimal adherence defined by rates of less than 90 or less than 85%. So this was basically a scenario where patients were missing maybe 1 dose per week. So not necessarily something that you would be particularly concerned about, perhaps. But what this group very elegantly showed was that the probability of achieving what we call a major molecular response, which is one of the key landmarks in CML management, was significantly reduced in patients who were basically missing 1 tablet a week. And in those patients who'd achieved what we call a cytogenetic response, the chances of losing that were again hugely higher in patients who were not fully adherent to their medication. And as you might imagine, there are not just clinical implications, but there are also economic implications from suboptimal adherence. And this was, again, a study from some time ago from the United States, demonstrating a significant increase in annual medical costs associated with what might, on the face of it, appear to be a fairly small reduction in adherence rates. So I just wanted to share an example from my clinical practice of perhaps how we can look at improving adherence and addressing these issues in our patients. So this is a female patient who was 43 years old. She had been diagnosed with chronic myeloid leukemia in 2015. And as I've mentioned, this is my area of speciality. So I run a pharmacist-led clinic in our hospital, and I see about 60 or 70 patients approximately every 3 months in this clinic. This patient had been taking a drug called nilotinib, which is a second-generation tyrosine kinase inhibitor for many years. And until the summer of 2021, she had basically been displaying an optimal response. There's a table on the right-hand side, which I won't explain in detail. Suffice to say that her molecular response to treatment had been excellent for many years. And the last test that had been undertaken in April 2021 had shown no evidence of disease by PCR testing. However, later in the year, we repeated this test for this patient because we were doing 6 monthly monitoring, and unexpectedly she'd lost her response and had a relatively high percentage of CML cells in the sample at 14%. We thought this might be a mistake, so we repeated the sample a few weeks later, and the percentage had now gone up to 29%. So this was clearly of significant clinical concern. We asked the question, could this be a mutation? We know that CML, as with all cancers, can mutate further and confer resistance to medication. Fortunately, there was no evidence of a mutation. And when we discussed the situation in detail with the patient, she admitted that she had not been taking her afternoon dose of her medication for a number of months. So she was due to take this drug twice a day. She would take it in the morning, and then she would forget to take it in the evening. So we had a long conversation with the patient about strategies to improve adherence, and we were able to offer her an app, which had just been launched in the UK called MyCML. So this was an app that I had some involvement with the development of, working closely with patient support groups in the UK. Again, that was critical to the success of the product. First of all, asking patient groups what they wanted an app to do, and then developing an app based on their responses. This app was launched in the beginning of 2022, and it provided a variety of functions for patients. The one that we were most interested in this particular case was the medication tracking function. And as you can see here, this allowed the patient to enter details of their medication and set reminders. In this particular example, it's set for imatinib. This patient was on nilotinib, so she was advised to set a reminder to take it twice a day. And she was also even able to set a reminder to remind her to fast before and after the dose. And so we sent her away with the app, and we were delighted that she achieved a positive outcome. As you can see on this graph, round about the end of 2021, her disease levels had shot up. You can see in that blue graph, and within 3 to 6 months of using the app and setting the reminder, she was back on track with her medication, and her disease control went back to an excellent level. So the patient was understandably delighted. We were delighted. And I think this is a nice example of using technology. And this is an app that is available worldwide. There are lots of other apps out there for lots of other types of cancer. But just to illustrate that something like that can make a huge difference to a person's clinical outcome. The second scenario that I want to talk briefly about is how we can improve pharmaceutical care for our patients undergoing allogeneic stem cell transplantation. So this is a specific form of treatment for a variety of type of blood cancers, particularly leukemias. And when patients are due to be admitted for a transplant, as clinical pharmacists, there are a variety of key patient-centered issues that we need to be thinking about. Nettie has already alluded to some of these already. We need to think about drug dosing. We need to think about drug interactions, drug toxicities, drug adherence. So these are very much focused on the patient, but also we need to be ideally having a conversation with the patient and not just simply looking at a prescription or looking at a set of notes to find out what makes that patient tick, what particular concerns they might have, and how we can best address them. So it's being person-centered rather than just patient-centered. So I just wanted to share a couple of initiatives that we've developed here in Birmingham to support patients through this journey, through what is actually a very intensive and relatively risky procedure. So before patients are admitted for their procedure, they get reviewed by one of our team, ideally face-to-face or potentially over the phone. We work through a checklist with the patients, and the aim is that prior to admission, we want to identify key clinical issues. So does the patient need dose adjustments of their chemotherapy, possibly due to obesity or issues with renal or hepatic function? Importantly, we want to get some background from the patient about what toxicity they've suffered with induction chemotherapy. For example, if they'd suffered from significant sickness, we can then intervene with stronger anti-sickness medicine when they come in for their transplant. We want to think about drug interactions, and we want to ask the patient whether they're good at swallowing tablets. Do they have adherence concerns? Again, all of these issues can be clinically significant, and it's important that we're individually asking our patients for information on these topics. Importantly, once we've undertaken the review, we share the results with the multidisciplinary team. So the pharmacy team, the medical team, the nursing team are all aware of issues specific to this patient. And if anyone is interested, we presented this work as a poster at an ISOP BOPA conference a number of years ago, and there's a reference on the screen. This is an example of the checklist that we use for our patients. I won't spend time going through it just now, but as I said, the idea is that we want to be ensuring that all the key clinical issues are discussed face-to-face with the patient before they come into hospital. Another big challenge in terms of managing these patients is when patients are ready to go home. And this again relates back to the issue of adherence. When patients come in for an allogeneic transplant, they are often on very little in the way of medication. They might be taking a tablet like acyclovir as an antiviral prophylaxis. Unfortunately, by the time they're ready to go home, things have changed. And in terms of their take-home medication, it looks a little bit more like this. So rather than one tablet, it might be a dozen tablets, plus some creams, plus some mouthwashes, etc. And so this is understandably overwhelming for our patients. So what we do is we make sure that every patient sees a member of the pharmacy team, and that could be a pharmacist or a senior pharmacy technician, for bespoke one-to-one counselling and education before they leave the ward. We aim to discuss all the medicines with the patient and relatives. We encourage relatives to attend so that there are more than one pair of ears to listen. And we produce a bespoke booklet for each patient. So this is an example of the sort of booklet that we produce. On the front, there is the patient details and some important background information and advice. The middle of the booklet is a table explaining the medication that the patient will be taking, when to take it and what it's for, and also how to take it. And then on the back, there is space to record doses of those medications where there may well be variable dosing. So cyclosporin is a drug that these patients take, and their dose generally varies from week to week. If they develop transplant complications, they often have to go onto steroids like prednisolone. And again, this is a really, a low-tech but highly effective way of ensuring that patient has some ownership over their medication, but also encourages them and empowers them to take their medication as prescribed. And finally, in terms of how we support our transplant patients, for over 20 years, we've had a pharmacist present in our transplant clinics to check prescriptions, to support our clinicians, and importantly, to counsel patients and update their booklets as required. And for the last 7 or 8 years, I've been working as a pharmacist prescriber in these clinics, again, reviewing patients in the early days post-transplant. So to conclude, and I apologize if I've slightly overrun, we all know that pharmacists are critically important members of the MDT team in the setting of cancer care. We need to often, it's important, I think, that we remind ourselves that pharmacists are trusted by patients, and particularly when we remind them that we are the experts on everything to do with their medicines. I think pharmacy as a profession, we sometimes are guilty of being a little bit shy and perhaps not blowing our trumpet enough. And it's very important that we make our voices heard when we are talking to patients, when we're discussing patients with our colleagues, because we are the experts on medicines. And we should always be looking to develop and share strategies, both low tech and high tech. I've given examples of both, I hope, in this presentation, so that we can better support our patients through their cancer journey. And finally, and most importantly, collaborating with our patients, with patient groups, with patient organizations, and with our clinical colleagues is key. And I think that's the joy of these sort of webinars. It allows us to share practice, to have conversations, you know, with on a global scale. And again, it's been a pleasure to present to you all this afternoon. So thank you very much.
Yeah, thank you so much for your presentation. It was really, really interesting, and I have so many questions we would like to discuss in a moment. So thanks again for your presentation, and it's my pleasure to move forward for the third presentation for today. So it's gonna be by Otuto Shukwu from Toronto, Canada. So Otuto is a PhD candidate in health policy at the University of Toronto. He's a licensed pharmacist with a multiple award-winning scholar and over a decade experience in health system strengthening and policy research. He supports the Lancet Commission on Cancer and Health Systems, and his PhD research is on exploring strategies to how to expand access to cancer care control services in low and middle income countries using pharmacists. So he's a Vanier Scholar and the 40 on the 40 Public Health Catalyst Awardee for 2022 from Boston Congress of Public Health USA. So it's a real pleasure to hear what you have to tell us about some task sharing with pharmacists to improve cancer care access in low and middle income countries. So the floor is all yours, and thank you for joining us today.
Yeah, thank you very much, Aline, and good afternoon, everyone. It's an honor to be here as we mark World Cancer Day, focusing on the critical theme, the role of pharmacists in the fight against cancer. The previous presenters have highlighted very important issues in a global context about pharmacists' roles in cancer treatment and adherence. We can all agree from their presentations and what we know that pharmacists are not only an integral part of the healthcare workforce, but are well-trained and suited to contribute to fighting the rising burden of cancer. These issues they have raised are critical for pharmacy practice in every setting. What I want to add is that in some settings, cancer care is not yet robust and pharmacists may be required to do more. This is particularly crucial in settings with severe shortage of oncologists and other cancer care workforce. So since task sharing has become a viable strategy to bridge gaps in care, we will focus our discussion on how pharmacists can play a pivotal role within this strategy, especially in low and middle income countries. And as we all know, for those that don't know, I'm telling you that cancer is a leading cause of death all around the world, with almost 10 million deaths occurring in 2020 alone. And the burden of cancer is even more severe in low and middle income countries, and that account for 70% of all cancer deaths worldwide. And it has been estimated that if nothing concrete is done about this, by 2040, which is less than 2 decades from now, cancer incidence in places like sub-Saharan Africa will increase by 92%. And this is nearly doubling within this period. So something has to be done. But with this rising incidence, many countries that are low-income countries face a severe shortage of trained cancer care workforce. For example, in Nigeria, where I'm from, there are fewer than 70 clinical oncologists serving a population of more than 220 million people. We have an annual cancer incidence of 100,000 cases, which means for every oncologist, we have 3,900 cases every year. And that makes you to not wonder much why 71% of the new cases we have die within their first year of diagnosis. So if you compare this to countries like Canada, where I'm currently studying, they have a ratio of 1 oncologist to 352 new cases, and in Australia, 1 to 272. And some countries are even faring worse than Nigeria. So for instance, in Rwanda and Sierra Leone, they have no single clinical oncologist. This is based on the latest evidence I have seen. So when you couple these grim, very grim statistics with evidence that suggests an aging cancer workforce, then you can ascertain that this burden will get worse. So it's critical for us to explore alternative workforce models, including tax sharing that involves pharmacists. Next slide, please. So one of the viable approaches for addressing workforce shortages generally is tax sharing, where you redistribute specific tasks from highly trained professionals to other trained healthcare providers. And this strategy has been effective in managing other non-communicable diseases like diabetes, like hypertension, and evidence that continues to emerge supports that it could be useful for cancer care. And because of this, I led a systematic review of task shifting in cancer care. And I found that various aspects of cancer care, for instance, screening, education, diagnosis, survivorship, have been successfully shifted to other health workers that are not oncologists. And in many cases, they resulted in outcomes that were comparable to usual care or even better than usual care. Next slide, please. Can I have the next slide? Okay, no, the one before that. Next slide. The one of, yes, this one. So there are several successful examples of tax sharing in cancer care to illustrate its potential. So for instance, in India, we saw that community health workers supported oral cancer screening, and this led to earlier detection of oral cancer. And most of the cases were diagnosed in the intervention group that comprises community health workers. And they also had a higher survival rate, and there was overall reduction in mortality. In Kenya, non-pathologist medical staff were trained to perform biopsies, and this led to a 41% increase in fine needle aspiration biopsies, and a 268% increase in bone marrow aspiration procedures. The research showed that quality of these procedures also improved, and patients were very satisfied. In fact, unsatisfactory reports from patients dropped from 14% to 4%. And in Ethiopia, we saw nurses improve breast cancer treatment adherence. These nurses provided communication by reminding patients to take their medicines, providing support, educating the patients on tamoxifen therapy after their surgery. And it was measured that adherence was higher after these interventions. And these examples demonstrate that task sharing, when you implement it properly, can enhance access to high quality cancer care and improve patient outcomes. So if this is the case for these other healthcare professionals, then pharmacists can do more with their advanced clinical knowledge, especially in low and middle income countries. Next slide, please. So why am I focusing on pharmacists? There are many reasons why we are crucial to addressing the rising burden of cancer in low and middle income countries. In many of these countries, in Nigeria, in Ghana, pharmacists are perceived by the public to be amongst the most trusted health professionals and are often the first port of call for health complaints and minor ailments. Also, we have the Doctor of Pharmacy degree program, which is now the mainstay in many low and middle income countries. And this only means that pharmacists now have more advanced clinical knowledge on various non-communicable diseases, including cancer. And then there is also the issue of health workforce migration, which continues to increase in many low and middle income countries and has continued to decrease the cancer workforce. But even though pharmacists with their specialized training are desired in other settings that could also migrate, various evidence have shown that they are less likely to migrate compared to physicians and other health workers because they face more stringent pathways to practice. And when you look at the workforce in many low and middle income countries, you can see that the pharmacy workforce is growing. So they have to be integrated somehow. But how do we go about this? It all boils down to acceptance by all members of the healthcare team, by collaboration and through policy initiatives. Next slide, please. So 2 years ago in Brisbane at the FIP Congress, I spoke about leading development of this framework, which we call the task shifting concept for pharmacies to advance cancer control and treatment. And I'm also using this framework for further research on pharmacy roles in cancer care, especially in low and middle income countries. And this framework brings together key concepts from various theories and frameworks, such as the intellectual capital theory, change management and motivation theories, to evaluate how cancer doctors, pharmacists, policymakers, patients, and everyone perceives tax shifting for pharmacists in low and middle income countries. And it's helping us now to understand some of the critical factors that are important, such as willingness of oncologists to delegate some of their tasks and to train pharmacists in performing some of these tasks. It looks at pharmacy skills and preparedness and how policymakers and patients can accept this model. And it also gives us insight on how to adapt cancer care strategies by learning from countries that have successfully implemented tax shifting, beyond just assessing the feasibility of tax shifting in low and middle income countries. It's a framework that can also guide us in developing some best practice guidelines that can help us to define pharmacist roles and to identify the key implementation factors and policy considerations, such as the appropriate settings for pharmacists to do more in cancer care, the remuneration models and strategies for sustainability. And this is part of what I'm currently researching, and I can't wait to share my findings and for us to operationalize pharmacist roles in cancer care in low and middle income countries. Next slide, please. But before we are able to get more involved in cancer care, there are some limitations we need to address. And one issue is the lack of oncology training for pharmacists in low and middle income countries. And this limits, the ability for us to take on expanded roles in these settings. There is also the issue of infrastructure gaps, including inadequate screening and diagnostic facilities. And this further restricts our ability to detect this disease early for prognosis to be better when you initiate treatment. And additionally, there are policy and regulatory barriers which often prevent pharmacists from fully participating in cancer care. And most of these center around concerns about role overlap with other professionals. But there are ways we can overcome these barriers, and we need targeted solutions, which can be in form of, expanding specialized oncology training for pharmacists, setting clear policy frameworks to advance and further define our roles in cancer care, and where applicable, ensure that the tax sharing we are proposing is structured. We can also strengthen collaboration across health professions. We can first of all create the understanding that people-centeredness is the key, and that sharing tasks and collaborating is for the purpose of saving lives and for the greater good of the healthcare system. And we as pharmacists need to show clearly that we have the capacity to support and perform tasks along the entire continuum of care for cancer. And we should also get involved. I keep advocating for pharmacists' involvement in policy and decision-making at the highest levels. We need to build allies at this level to ensure that we have voices that can make a case as to our capabilities in cancer care. And we should also show these capabilities by getting involved as much as we can beyond dispensing medications. Next slide, please. So I believe that our advanced clinical knowledge must continue to count for something. And in many high-income countries, this is already the case, where pharmacists are handling advanced roles in cancer care. So for example, in Denmark and Portugal, community pharmacists administer vaccines against hepatitis B and HPV, human papillomavirus, to prevent liver and cervical cancers. In Belgium and Netherlands, cancer patients are assigned a family pharmacist, which they call a pharma body, to support with medication therapy management and palliative care. And from what I have seen, what I read, this service is offered by 80% of community pharmacists in Belgium and reached over 600,000 patients in the first year. In Norway, pharmacists screen for dermatological cancers, and all the people screened in the pharmacy said it was a suitable setting and they were satisfied with this service. So this tells us that integrating pharmacists into cancer care teams can help bridge these gaps in service delivery, and it can ensure that patients receive timely, high-quality care, and it can help us alleviate the burden, the workforce burden, and contribute to reducing the general burden of cancer in low and middle income countries. So we can adopt some of these models and some of these examples from high income countries. Next slide, please. So I'll be concluding with a call to action for a tax sharing model for pharmacists in low and middle income countries, so that we can contribute to curbing the rising burden of cancer. And with our expanding roles, pharmacists can significantly contribute to cancer care and control. However, for us to realize this vision, we need to invest in oncology training to further equip us with the necessary skills and knowledge to contribute. We need to establish clear policy frameworks to support and regulate tax sharing. We need to foster strong interdisciplinary collaboration between pharmacists, oncologists, and other providers, to help us ensure that patient care is seamless. And finally, we need further research to refine tax sharing models and assess their long-term impact on cancer outcomes. We as pharmacists should be leading this research and pushing for these actions. And as Nick said earlier, we should blow our trumpet, and we should show we can do all of these things. And it could help us ensure ultimately that at the end, more people, especially those in underserved communities, they receive the cancer care they need and the cancer care they deserve. Thank you for listening.
Thank you so much, Otuto, for this excellent presentation and for ending it with this powerful message. So I really would like to thank you and thank all the panelists and speakers today for this insightful presentations and then this excellent webinar. So for now, I would like to invite all our speakers to get back to us and to open their cameras so we can discuss, to have the Q&A questions and the section. So I have to tell you, we have a lot of questions. So that means that was a really good webinar, if I can say. So just to gain time, I would like to maybe start with maybe the message Otuto ended with regarding challenges, especially related to the need to have maybe more education and to have more specialized training and so on. So maybe Nettie, I would like to start with you regarding these challenges and how we can, we have different people from the audience asking about courses, about support, how ISOP would help us, for example, or help any pharmacist to get more experience with cancer practice and eventually to have more support in courses and so on. Can you give us a highlight on how to access to this information, please?
Yes, of course. So cancer training and the education that's required to become a specialist cancer pharmacist is obviously quite intense because it is such a complex area. However, there are, so personally, I know of a free course that is available through BOPA, which is the British Oncology Pharmacy Association. It's called the Let's Communicate Cancer course, the LCC course, and this is aimed at pharmacists in community or outside of a hospital setting around early detection and prevention of cancer. So that's something that we could all do, and that's available free. With regards to almost like an introduction to cancer course, so you're looking at learning about extravasation, oncological emergencies, nausea and vomiting, and how to manage the basics of cancer care. This is something that ISOP are looking at potentially producing some form of e-learning course. We haven't got there yet. We have slightly more information with regards to the UTIC course. There is also another e-learning course that is free for ISOP members called the OPAB course, and that looks around the clinical treatments of cancer. So it breaks it down into the different tumour sites such as breast and colorectal. And that's free for ISOP members. And it also looks, someone made a comment or a question around monoclonal antibodies, and I was wondering if that was around biosimilars. And it's also around how you can implement biosimilars into your workforce. We're also looking at ISOP around a course for safe handling, because obviously these are toxic drugs. And again, we're in the early stages of developing that. So there's lots of courses that ISOP want to run and send out to people, which will be free for ISOP members. There's also what we can do as a society is we can go to different countries and run regional symposia. So we can tailor a whole training program or symposium around what the needs are for that demographic, and we'll do that in partnership with the pharmacists there. And likewise, we can do something called workshops as well. So we have workshops on immunotherapy, for example, and supportive care, which we're running in Canada in April, but we can run these anywhere in the world. There is, obviously they cost money because we need people to get there, but there are ways around potentially asking governments to help support with education and training in specific countries. So if anyone wants to reach out with regards to how ISOP can help specifically for that, they can do that directly. And my email is very simply president@isop.org. So.
Okay, so I invite everyone to get in contact with you, eventually go to your website and check all the resources available so they can help them with improving their knowledge skills and eventually have tailored, maybe some tailored webinars or whatever. So thank you so much. Nick, I would like to ask you, because so many, you discussed a very important point about adherence to treatment, and we had some comments related to that. So I have like three not main questions, but three questions related to adherence. So one of the questions was asking about the best scales available to measure medication adherence, and what would be the sources available to study the criteria related to considered about adherence. Would you like me to go over the three questions and then, or we can go over one by one? It would be better. Yeah.
Maybe one by one. My memory is likely to fail me if I try and remember three at the same time.
Okay, excellent.
The question about adherence scales is a really good question, and it's a difficult one to answer. I think there are a lot of scales out there. Probably the most well used one is the Maritsky medication adherence scale. That's been around for a number of decades, and I think if you look at adherence publications, that's the one that's most likely used in terms of that sort of questionnaire approach. I mean, obviously, to emphasize, there's lots of other ways of measuring adherence, and that could be pill counts or dispensing records, or clever chemistry measuring blood levels and such like. But in terms of a questionnaire, Maritsky is probably the first place to start. I haven't used it very much myself. I suspect that you might have to pay to use it.
Exactly.
Which I think is a downside.
I wanted to highlight that for the researchers to know that you can't use it without asking for permission to use it. So it's important to get eventually in contact with the main author and to get approval, or eventually to pay. Depending on the research project, you will have to pay or not. So just to make sure they understand. But it's good to know that there are different other maybe free scales that are available, and some of them have been also validated in several countries that take into account that some specifics of each of the society. So it's important to get to know the literature as well when we have to do any research project. Okay, excellent. So this was about the scale. The second point I would like to highlight, because you said, and this is an important thing we see every day in our clinics related to adherence treatment, some patients would have less efficacy, would have maybe relapse, would have resistance to treatment, and so on. So it is a very important thing. But you discussed that. I would like to highlight 2 points. So I would like to ask you, because sometimes the adherence to treatment is not only related to because they forgot to take it. Some patients would stop taking it because of the side effects, especially with the example you gave about tamoxifen. Many people would have musculoskeletal pain or eventually heat or something, and they tell us we can't bear it anymore, and we stopped it because I can't handle it anymore. So when you have a patient like that, what would you suggest? How a pharmacist can help support the patient in helping them get their medication anyway and eventually keep them on the right track for treatment?
I think as pharmacists, we are so well placed to support this aspect. So first of all, in terms of adherence, I think we're more interested than any other group in adherence. But then we've also, I think, got the skill set to deal with exactly that scenario, Aline, that you mentioned, and that's something that we see very commonly. So this is sort of intentional non-adherence driven by side effects, and we know that whatever drug patients are on, the chances are they will have some side effects. And I think, using my kind of CML clinic as an example, I think it's a good example because these are patients taking a drug probably for 10, 20, 30 years that is keeping them alive and will hopefully give them a normal life expectancy. So from a medical position, if you take a sort of step back, you can say, well, this is great. This is a great drug. The patient's blood results are excellent. I'm just going to keep prescribing it for them. Everything is fine. But that poor patient is at home with nausea, with diarrhea, with muscular aches, with, fatigue. These aren't life-threatening side effects, so they're probably not going to contact us to, to flag them up. So that's why it's very important when we're talking to patients that we actually explore these sort of low-level side effects, because actually from a quality of life point of view, they're hugely significant and absolutely impact on adherence. So within my clinic, the couple of things I would aim to do would be have that conversation with patients and make sure we know exactly what's going on. For some side effects, they're relatively easy to manage. So a lot of our patients get diarrhea with their tyrosine kinase inhibitors, and we give them loperamide, and they take a loperamide once in the morning with their imatinib, and their bowels are well controlled. The other thing that we often talk about with our patients is dose adjustments. So again, it's giving patients that, having the conversation to say, what you're doing very well, maybe we can actually put you on a lower dose of your drug. We might do some extra monitoring, and again, patients are generally quite keen to try anything. And again, depending on the cancer, depending on the situation, these options may be more or less appropriate. But I think they're kind of the key points I'd want to make.
Yeah, we should have a good communication with the patient. That's the key point maybe that we could highlight. Thank you so much. Tuto, we have a question related to, it's a very important thing discussing the low and the middle income countries, because most of the time what has been suggested, for example, by Nettie or Nick, that are more in developed countries, so such as digital applications and so on, they might not be available in our low or middle income countries. So the question would be, we have several challenges, yes, but how can we push the implementation of policy changes? How can we help, for example, these services to be implemented? What do you think? You suggested a framework already, but I would like to hear you about if a country does not have even a specialized domain in cancer for the pharmacists, for the pharmacists, how do you suggest we can start with something to help these countries at least implement something they can help whether in a healthcare setting or eventually in their community pharmacist?
Yeah, thank you very much, Aline, for that question. So for me, there are three key things I would like to see some of these countries do. And the first is, that specialized training for pharmacists, where governments through their ministries of health can partner with academic institutions to establish, oncology training programs and residency certifications and all of those things required to equip pharmacists with the skills for expanded roles in cancer care. And then all of this has to happen within a defined policy and regulatory framework. So some form of reform around this, where again, ministries of health and other stakeholders from the private sector and NGO community, development partners come together, see what they can learn from other countries and, revise or in places where they don't exist, create scope of practice regulations for pharmacists to, establish based on evidence what allows pharmacists to participate in expanded roles in cancer care, for instance, screening, survivorship, medication therapy management. And, like Nick said, I think it was Nick, around digital health. So we need investments around this area, where we can have maybe tele-oncology platforms and other decision support tools through which pharmacists can connect with oncologists to expand access in underserved areas.
Mm-hmm. Yeah, this is really interesting. And eventually you highlighted the importance of academia, the importance of all stakeholders in implementing this. And this brings me to Nettie back again. I would like to ask you if some government or eventually maybe some people from pharmacy organizations such as the Order of Pharmacists also would like to implement, or even academia would like to implement this strategy. Would you help in the implementation of these strategies regarding, for example, the support for these pharmacists how can you support these countries that do not have enough resources, for example, other than what you suggested about courses, training, and so on? Are you able to involve with the stakeholders regarding their demand, special demand, for example?
Yeah, ISOP can definitely help support those countries where they don't have oncology pharmacy established yet within their country. So by joining ISOP, you get a group of pharmacists from a particular country who haven't got that speciality yet, and then we can help with regards to mentoring them and supporting them to be able to get that seen within their country and established within their country. And that's where we go out and help with, like, for example, with regional symposia, but also help with one example is we have our ISOP standards of practice paper, and people have used that to lobby for the government for support with regards to getting oncology pharmacists seen as a speciality.
Excellent. Okay, thank you. Nick, I was curious to know if a patient, because I know that you're a specialist in oncology and you run a clinic for patients with the leukemia. But I was like curious to know, did you ever encounter any problem with patients who would like wanting to see a doctor rather than a pharmacist when stepping into a clinic? How would that happen? And could you tell us more about it, please?
Yeah, it's a really good question. And I think when I first started out working in clinics, I was very nervous about that aspect. Again, it's this whole idea where as a pharmacist, you perhaps feel a little bit, lacking in confidence. And I think I did have a concern that patients would be unhappy to be seeing a pharmacist, even, an experienced pharmacist. But in reality, and I've been doing clinics for maybe eight or so years, it has happened very rarely. So I was relieved. I think this was just me maybe worrying more than I should have done. Very occasionally, patients are surprised that they are seeing a pharmacist. Maybe they were expecting to see the doctor. And then I think it's very important that you explain, first of all, that you are the pharmacist and why they are seeing you and not a doctor, and often I see patients who maybe are on polypharmacy just after a bone marrow transplant, and I can say to them, well, you're on so many tablets at the moment, it makes sense that you see me this week and we can spend some time talking about your medication and making sure that everything is optimized. And then maybe next week, we'll book you back in to see one of the doctors. What we try and operate is a multidisciplinary clinic. And I think it's as the others have alluded, a lot of this is about skill mix and task sharing. And that applies, in all healthcare settings. So in the UK, we've had this big move away from patients seeing a doctor every time they come to clinic and seeing a pharmacist or a specialist nurse. And we find the model works very well, but it's really important that you explain what's going on. And generally when you give that explanation, and again, it's making that point, I'm the expert on drugs, you're on lots of drugs, therefore I'm a good person to see. And patients get it. And ultimately, if a patient is really unhappy and says, I want to see the doctor, then maybe you just have to say, okay, you can see the doctor. There's no point being precious about it. Again, it has to be about the patient. And if the patient is genuinely not happy to see someone else, then wherever possible, you want to respect that decision.
Yeah, definitely. No, excellent. Really, really interesting. And here I would like to hear Tuto about, because we've been discussing since the beginning of this webinar about task sharing in healthcare and how we can work within a multidisciplinary team and so on. But I would like to ask you, because it might be like one would think that if I'm not working alone, but I'm working within a multidisciplinary team, that might maybe compromise the quality of care, especially in these complex fields like cancer and oncology. So how would you say that this task sharing involving pharmacists could not only maintain, but even improve the quality of care regarding the people-centered care?
Yeah, thank you, Aline. That's a very valid concern, regarding quality of care, especially with a complex disease like cancer. But what evidence shows us is that task sharing, if it's implemented properly, where you have adequate training, adequate supervision, there are clear guidelines, it can even maintain or even improve patient outcomes, as we saw from some of the evidences I shared earlier. There have been studies to confirm that when pharmacists are integrated properly with the right training and with the right exposure and supervision, they can help manage medications, help educate patients, and this often leads to better patient engagement and better outcomes. So it's all about the framework within which this is operationalized. If you are able to do it properly, make sure every member of the healthcare team is on board and they understand that pharmacists can, do more beyond dispensing oncology medicines and managing those medications. They can help in screening, in diagnosis, in survivorship, and they provide examples where these have been implemented, and then, contextualize how this was done within your own setting. It shouldn't be a problem. It should rather improve quality rather than diminish it. But there should be clear boundaries.
Yeah, excellent. Yeah, exactly. So in this regard, Nick, I would like maybe to ask you for on a daily task, maybe could you give us a little bit how the patient, is it referred to your clinic? The patient, would it be referred to your clinic, or they come by their own, and what do you do on a daily like follow up with the patient for delivering a patient-centered care? So can you tell us as a pharmacist how we can deal with it?
I guess the models will vary quite significantly depending on your patient population, depending on your locality, depending on the structure of your clinic's setup. So although I work in 2 or 3 different clinics, but I have slightly different roles and different responsibilities. So for example, in the chronic myeloid leukemia, the CML clinic, these are stable patients. They've been on treatment often for many years, and they generally just see me. I have a medical consultant who I work with, but he has his own very large list of patients to see. So we split the patients, and obviously if I see a patient who I am concerned about from a clinical point of view, then I can refer them back to my consultant colleague. And similarly, if he has a patient who he feels is doing well and does not need his input anymore, he will send them to me and I will manage them going forward. And that model works very well. And then I can design my clinic to try and be as patient centered as possible. So for some patients, I will offer them a face-to-face consultation. Some of them I will have a telephone consultation. Some of them will want me to contact them when their blood results are available. Some people will say, that's fine, I'm back in clinic in 3 months, I can wait till then. So I think it's important that, you know, the CML population is to some extent quite homogenous, but it's important that you don't lose sight of each individual patient, and you make sure that you're delivering a service that works for them.
Excellent. Thank you so much. It was really a pleasure discussing with you. I'm sorry we run out of time. We still have too much questions to discuss, but hopefully we will do it in another webinar. So I would like to close up with two last messages. First, thank you all for being here. Thank you for the panelists and the speakers for the excellent presentations and the insights. I would like to remind everyone that this episode will be recorded and available at the website of the FIP. And eventually we would like to you can visit the FIP for all other future events. And a final reminder for the World Congress of FIP that would be held in Copenhagen in Denmark, the latest 31st August until September 3rd. So we hope to see you all there. Thank you so much for listening and for being with us today. And hopefully we'll see you in other meetings and webinars. Thanks a lot.